Hi friends, welcome to classes by Lab Doctor. In today's class, we will discuss about hyponatremia. So, the normal range of sodium lies between 135 to 145 milliequivalents per liter. So, when the sodium levels falls less than 120 milliequivalents per liter, this value is alarming and the clinician has to be informed. If the sodium value goes beyond 160 milliequivalents per liter, that is also very critical. So whenever there is hyponatremia, too rapidly you have corrected this hyponatremia, that also can cause damage. It can lead to central pontine myelin lysis, because when you correct the hyponatremia very quickly, sodium level will rise very rapidly. So when the sodium level will rise very rapidly, it will pull the water from the brain cells and it will damage the myelin and the nerve cells. So this damage mostly occurs in the pons. So that is why too rapid correction of hyponatremia is not advised. And also too slow correction, अगर आपने बहुत slowly hyponatremia को correct कर दिया, that can also cause cerebral edema, because when sodium level is low, water moves from the bloodstream into the brain cells, causing them to swell. So too slow and too quick correction of hyponatremia can be very dangerous. So I've told you hyponatremia when it is less than 135 milliequivalents per liter, hypernatremia when the level of sodium is more than 145 milliequivalents per liter. So we can categorize the hyponatremia as mild, moderate and severe. Mild is when the sodium levels are between 135 to 130. Patient usually has no symptoms. Suppose if the sodium levels falls less than 130. So it is something between 125 to 130. Then the patient will have nausea, he might have confusion, headache, etc. And severe when the level of sodium falls less than 125 or 120. So a patient will have vomiting, cardiorespiratory failure, he might have convulsions, coma, drowsiness, etc. So the main thing I have told you in the pathophysiology of hyponatremia is the cells swell. The cells will be swollen in hyponatremia because of the imbalance of the water and sodium in the body. So what happens to the sodium levels? Sodium levels will be very less. Sodium is seen mostly in the extracellular fluid. In hyponatremia, what happens? The sodium level is very low. So water moves into the cell to compensate. This is because the sodium is an electrolyte that helps them maintain the balance of water and electrolytes in the body. So this cell swelling causes a lot of damage, especially in the brain. So I've told you sodium is mostly located in the extracellular space, that too in the interstitial space. The main concentration of sodium is extracellular. So this sodium is maintained, the level of sodium and water in the body is regulated by various hormones. Like you have the ADH, you have the aldosterone system, renin, angiotensin, aldosterone system, etc. So this ADH, so this is produced by the posterior pituitary, and what this ADH will do, anti-diuresis, it will inhibit the formation of urine, so it will stop the loss of water from the body. So when it will retain this water, it will try to increase the blood pressure. So that is how this ADH will try to maintain the water balance. Sodium or the water levels in the body changes. Another hormone system which comes into play is the renin angiotensin system. Whenever there is a drop in the blood pressure, the kidneys will release renin, the liver, the angiotensin engine will get converted into angiotensin 1, angiotensin 2, that will activate the aldosterone, and this aldosterone will help us to hold on water and sodium. It will reabsorb the sodium and water, and that will help in the maintenance of the blood pressure. Remember, hyponatremia is not a disease. there is something which is causing hyponatremia. So it is just a clue to a disease. So we have to find out what is the cause, what is the history of the patient. We have to examine the patient. We might have to do certain tests to find out what is the actual cause of hyponatremia. We will also have to see the osmolality, the serum osmolality, the urine osmolality. We will have to see the fluid status of the patient. We will also have to see the serum sodium levels, the urine sodium levels to come to a conclusion. So hyponatremia is not a disease, it is just a clue to a underlying cause. So suppose if the sodium is less than 135 millimoles per liter, we will have to see the plasma osmolality. Plasma osmolality is the concentration of the solutes which is present in the plasma now. So whether it is low, whether it is normal, or whether it is high. In some conditions you might get a normal osmolality. The patient is having low sodium. So when this can happen in pseudo hyponatremia. So pseudo hyponatremia, what happens if this is a normal, where you can see that this is the water contents and this here you can see the plasma volume. In hyperlipidemia or hyperproteinemia or hyperglycemia, what happens, this plasma volume will be expanded and this sodium appears less. So it is pseudo, the actual sodium has not reduced, but because of the increase of these lipids or the proteins or the glucose, the sodium appears less. So that is called as pseudo hyponatremia. Now comes isotonic hyponatremia. So what happens in isotonic hyponatremia? So suppose if you give isotonic fluids and the ECF will expand definitely because you have given them the fluid, but the concentration of solute is the same. So there is no shift which is occurring. So the sodium concentration is the same. So when the sodium concentration is the same, osmolality will be same because osmolality is 2 times the sodium. But the sodium levels now appear little low. What happens in hypertonic hyponatremia? Suppose if you have added a hypertonic solution, hypertonic mannitol, so the fluid concentration will be more, extracellular fluid will be more. So the hypertonics, the concentration of solute is also more. So the ECF is definitely going to expand. Because the concentration of solute is more, so what happens? The ICF is going to shrink because the concentration is more outside. The fluid will shift from ICF to ECF. So the shrinkage of the cells occur here. And in hypotonic hyponatremia, so this is the most common type of hyponatremia or the true hyponatremia. So what happens here is the when you add the fluid hypotonic solution, the extracellular fluid will expand, but the concentration of solute in the extracellular fluid is less comparatively to the intracellular fluid. So the solute will shift from the ECF to ICF. So there is swelling of this cell. So this is the most common type of hyponatremia we will see. The sodium levels appear to be low because of increase in the level of water. Whenever there is hyponatremia, we need to assess whether the patient is euvolumic or hypovolumic or hypervolumic. How do we know the total body water? How do we assess his total body water? We will see the change in the weight. We will see his fluid intake, fluid output, whether it is same. We will see the blood pressure. We will see the heart rate. We will see his laboratory investigation for the electrolytes, serum urea, creatinine. We will see the plasma osmolality, the urine osmolality. We will see his eyes. We will see the mucous membrane if it is dry. We will see the elasticity, the skin turgor. We will see the urine color, the excessive thirst, the cramping. All this will tell us the body water status. Sodium concentration is less than 135 millimoles per liter. You should assess the plasma osmolality. So suppose if the plasma osmolality is normal, it is mostly pseudo hyponatremia. If the plasma osmolality is very high, then it can be translocational hyponatremia. And suppose if the plasma osmolality is low, then this is mostly the true hyponatremia. So we have to assess the fluid status, whether the patient is hypovolumic, euvolumic or hypervolumic. So what are the conditions which can cause hypovolumia and low sodium concentration? So conditions which can cause hypovolumia are could be extrarenal or could be renal. Now extrarenal are vomiting, diarrhea, if the patient is losing blood, if there is burns, if there is excessive sweating, all this can cause loss of water as well as loss of salts from the patient. That can cause hypovolumic hyponatremia. So that is the extrarenal causes. Now there could be some condition, renal condition, where there could be loss of fluid as well as loss of salts. For example, if the patient is having a diuretic excess, so there is increased amount of urine which is going, there is loss of fluid and salt is also going. Mineralocorticoid deficiency, there is a salt losing nephropathy. In such conditions, the body will lose water as well as the body will lose the salt, now the sodium. So this is the most common cause, that is hypovolumic hyponatremia. So suppose if it is an extra renal cause, suppose if it is because of vomiting or loose motion etc., the kidney will be normal, so the renal excretion of sodium will be less. Whereas if there is a problem in the kidney and then we are getting low sodium, we are getting low fluids, hypovolumia, that means the sodium excretion in the kidney also will be more. So the fractional excretion of sodium will be more because kidney is at damage here. So now the hyponatremia can be because of hypervolumia also. Hypervolumia means the sodium is less but the body fluids are more. For example, in the edematous stages, in heart failure, in cirrhosis, in nephrotic syndrome. So all this condition, what happens? The volume of the water is more. Make the salt appear less. The sodium concentration appears less. So that is hypervolumic hyponatremia. So this also can be divided into renal and extra renal. So if it is extra renal, the causes I have told you, it could be nephrotic syndrome, it could be cirrhosis, it could be heart failure. Suppose if it is kidney causes, like it could be acute kidney injury, chronic kidney diseases, then also there can be low sodium but increased water in the body. There is a third condition wherein the volume of the water is same but the concentration of sodium is less. So like in a case of glucocorticoid deficiency, in case of hypothyroidism, or if there is an water intoxication, SIADH. So these are the causes for euvolumic hyponatremia. Whenever there is an hyponatremia, first rule out whether it is pseudo-hyponatremia, whether the low sodium what we are seeing, it is actual hyponatremia or it is just because of an increased sodium, increased triglycerides or increased glucose or increased lipid in his blood. So that can also cause hyponatremia. So first thing is we have to rule out pseudo-hyponatremia. Then we have to see whether it is dilutional, that is the water content is more, that is making the sodium appear less, like in case of congestive heart failure, nephrotic syndrome, cirrhosis of liver. The water level in the body will be so much that the salt appears less. Then there could be some primary causes like polydipsia, or there can be diuretic intake, or there can be dehydration, beer protomania, wherein the patient only drinks beer, he doesn't consume food, or the patient is having just tea and toast, tea toast diet, where the patient is having only water, or he doesn't have enough of salts in his food or drink. So that can also causes this kind of an hyponatremia. Other are hormone related, like it could be hypothyroidism or it could be syndrome of inappropriate antidiuretic hormone secretion. So whenever the patient is having hypovolumia, that can cause decreased in the sodium, and then the patient will have hypotension, tachycardia, poor skin turgor. Suppose if the patient is having less of sodium but the water level in his body is okay, then the patient usually will have normal blood pressure, he will have normal pulse, there will be no edema. Suppose if the patient is having low sodium and increased water in his body, then the patient might have edema. So symptoms of hyponatremia are mild, moderate, severe and extreme. So mild patient may have nausea, headache, fatigue. In moderate, patient has confusion, muscle cramps, altered mental status. And in severe, patients will have convulsions, they will have respiratory distress, coma and even death also. If the patient is having hypovolemia, we need to treat the patient with isotonic saline. If the patient is hypervolumic, we need to restrict the sodium, water. We might have to give him diuretic. So according to the cause, the case has to be treated. So that is all about hyponatremia. Thank you so much for watching the video. Please like, share and subscribe the channel. Thank you.